Welcome to the latest episode of the Mind Gut Conversation podcast, a place to learn about new ideas from thought leaders in the area of optimal health and the science of mind gut microbiome interactions. Today, I have the great pleasure to speak to Dr. Laurie Keefer, a health psychologist and professor of medicine and psychiatry at the Icahn School of Medicine at Mount Sinai in New York City. She established the first clinically integrated gastropsychology program at Rush University Medical Center in Chicago in 2004 and has been a champion for integrated psychosocial care in gastroenterology settings and training many in this model around the world. Dr. Keefer's scientific contributions include the development and implementation of self-management and behavioral intervention tools, known as brain-gut behavior therapies for conditions such as Crohn's disease, ulcerative colitis, IBS, and gastroesophageal reflux disease. She's the inventor of the GRIT method, a systematic approach to risk stratification, team communication, and personalized care planning for patients with chronic conditions seen in multidisciplinary settings. Dr. Keefer is founder and chair of the Rome Foundation's International GastroPsych organization and serves on the board of directors of the Rome Foundation. She has more than 250 peer-reviewed publications and is a sought-after speaker, mentor, and collaborator. Welcome to the show, Laurie. Okay, so hi, Laurie. It's a great pleasure to talk to you today.
Thank you for having me.
Yeah, no, it's one of the topics. So sometimes when I do these podcasts, I'm not really the expert. In this case, I have a strong interest, as you know, in this topic as well, and so I'm looking forward to this exchange. Let me ask you as a general question, as a health psychologist, how did you get interested in the area of chronic gastrointestinal disorders?
That's a great question. I kind of joke that I'm the accidental gastropsychologist, right? So I think with anything, the more you learn about something, the more passionate you become about it. And so even when I was in graduate school, my first independent study was on Herbert Benson's relaxation response meditation for irritable bowel syndrome. I worked with Ed Blanchard, who was my PhD mentor. And I remember kind of going back to my colleague saying, he wants me to study this thing called IBS. Like, what am I going to tell my parents? I went to school for psychology, right? All the stigma, I think, that our patients experience of bowels and talking about it. But everyone said, do the study. It's not going to be the rest of your life. It's just one study. But then I did the study and I loved the patients. I loved the fact that you could do a mind intervention for a body issue. And to me, as a young PhD student, I really hadn't been exposed to that in graduate school or in undergrad, right? And so just that idea, I mean, now it's a no-brainer, but back then I remember being like, wow, psychologists can actually influence medical conditions. And that was sort of the formation of my career since then.
Yeah, really interesting. I mean, obviously there have been so many changes, in both the names that we give these disorders and going away from like when I started seeing patients, the time was if you mentioned the word psychology or psychological, it was a stigma, that nobody wanted to do that stigma. And for physicians, this was a good reason to discard it and not spend any more time on it. So now it's almost like a 180-degree turnaround that,
Yeah.
gut disorders and which incorporate the brain gut disorders have sort of become like it's one of the most common themes on the internet and social media.
Yeah.
So it's
Yeah.
quite.
When I was, younger in through grad school and into my early career, right, we were still talking about things like irritable bowel syndrome as a physical manifestation of worry. And that was how all the early cognitive behavior therapy protocols came about. We thought if you treat the worry, you'll treat the bowels, right? And then your work, I remember that was really kind of like the hot thing when I was studying in grad school, your work with the brain imaging and labeling things like visceral hypersensitivity, and that there were actual, there was a brain neurological basis or biological basis to these issues. Really, exploded the field that allowed gastropsychologists a way in without seeming so, like you said, it's all in your head, it's all psychological.
Yeah, no, this is a really great thing that that this has happened. I'll come back to this. Um, so it's, you know, it's, I'm always amazed. It's taken almost 40 years for the, authorities to accept the name disorders of gut-brain interactions, or DGBIs, for what used to be called functional GI disorders. Um, So, why do you think it's taken so long? Because there's been an ongoing discussion over these 40 years. Um, you have been involved in these discussions. Finally, you are being accepted as an authority that everybody, physicians listen to. But why
Yeah.
is it taken? Why is it taken so long?
I think that unfortunately, medicine continues to dichotomize brain and body, right? And so I think in GI, it's really one of the few disease states where we can call something a disorder of gut-brain interaction, right? There's very few other fields that kind of like combine those two terms in the same diagnosis.
Yeah.
And so, but I don't think that that's how our training is set up. And we've actually done some recent surveys around trainees around treating disorders of gut-brain interaction. And they're indicating not only are they not exposed to this concept of brain gut being bidirectional, they're taught that these disorders are things you don't want to treat. They don't have the confidence to treat them. They don't know what to say or do. And I think a lot of what I do as a psychologist is model some of the language, right? How we talk about it, building the confidence of the physicians. I always say, master your elevator pitch here. Be able to start out with the story of the gut and the brain are always bidirectional communication. It's not just in the functional disorders, right? It's all of them. But it's very hard to kind of convey that the way that we currently teach medical students.
Um, yes, this is a little bit like a redundant question. In your opinion, why has this aspect of of brain-gut interactions remained a neglected area in gastroenterology, and still remains in, we were talking about this earlier, in the field of inflammatory bowel disorders. So it's gradually being accepted in DGBIs, but in inflammatory disorders, this is still a foreign language. This is not something that people think and I think it's sort of a common perception is with the biologics, we have that essentially the effectiveness of these medication proves that it's all in the immune system and there's nothing else that plays a role.
Yep. Yeah, I think that for me, because I started in the IBD research, in the early 2000s, right? And at that point, we weren't looking at those endpoints like mucosal healing. Everything was very symptom based. And there was sort of this attitude of if the patient has symptoms, they must be inflammation based, they must be immune based, they must be in flare, right? And our treatments were always around, my role as a psychologist was always to help patients tolerate that cross your fingers approach to when am I going to flare again? And is there anything I can do to prevent that inevitable flare, right? And now we have so many different immune pathways. We're no longer just on anti-TNF. And, we're able to see mucosal healing earlier on, and the doctors are more confident in saying what is inflammation and what is not. All of those early clinical trials where you had 40 to 60% placebo rates because there was no way of measuring mucosal healing, has made it so much harder now to really come up with an efficacious drug that's really kind of like, we got this. And I think honestly, that may be partly why we're starting to be able to look into brain gut again, right? Because what is that explanation? You have mucosal healing, but you're still complaining of bowel urgency. You're still complaining of fatigue. There's a lot there now that we used to just attribute to, oh, you have Crohn's, of course you're depressed, of course you're tired, of course you're disabled. And now it's like, you have Crohn's, you have mucosal healing, why are you behaving this way?
Yeah, and there are clearly some interesting aspects about the inflammatory, part of it, because you were talking about the bidirectional communication between the gut and the brain. So we know now also something that's not made it into common knowledge in the IBD field, that these inflammatory bowel disorders, if you look at large epidemiological studies, are a risk factor for developing early cognitive decline, and there's brain changes
Yeah.
induced by the inflammation. And we know, there's glial cells and immune cells in the brain that get activated by signals from the gut. So we know that part as well. So the inflammation does do, damage to the brain. It's not something but I think the more common thing that people talk about is this whole, and you were a co-author on a paper several years ago on where you looked at sort of the prevalence of anxiety and depression in inflammatory bowel disorders.
Yeah.
And there, it's not as clear. So I personally don't think that anxiety, that inflammation plays a significant role, maybe in some form of depression. But then there's this whole pain area where we've written this review article about that you can have the pain or the urgency without any inflammation,
Right.
so um,
Right.
it is kind of amazing when you think about, so people have a disease that's a risk factor for early cognitive decline. I mean, everybody now talks about, Alzheimer's disease and how it's increasing in the population. But this topic rarely comes up, that
No,
gut
exactly.
could actually play a role in this as well.
Yep. Yeah. And I mean, I think a lot of these disorders are disorders of younger people when they're diagnosed, right? And so I think we don't necessarily do a good service of teaching early on long-standing self-management behaviors, right? And if you think about when you're diagnosed with like Crohn's or ulcerative colitis, you're usually like under 30. I mean, we do see this bimodal distribution now, where you have some older folks, but at that age, you're not really thinking about getting cognitive decline. You're not thinking about the impact of not taking care of these inflammatory processes, your diet, your, stress relief, your exercise, all of those issues.
So in your recommendations about patients, so lifestyle is a big thing now, and diet is one part of this. And obviously, you know, therapeutic components targeted at the brain, at the mind, play a big role. Do you recommend now to your patients this whole range of treatments? So like a holistic approach, not just one thing. So if you have chronic pain in a state of mucosal healing, you don't just recommend one thing. You recommend the whole lifestyle.
Right. I mean, right. I mean, chronic pain is something that, number one, I think we kind of have to move away from this idea that it's going to go away. Right. And, certainly for some people that's fantastic if they have pain for a year or two and then they recover and they move on. But I think the first step here is just being able to recognize that this is a chronic condition, just like my Crohn's, just like my IBS, just like my ulcerative colitis, whatever. And recognizing that means you have to be proactive the rest of your life. And so that can mean a lot of different things at a lot of different times. And moving away from that search for, I need a cure, I need an answer, I need a solution, I need a pill, and really recognizing that your body's chronic pain is begging you to think about yourself more holistically, right? And really care for yourself. And, I don't really, to me, if they're willing to do something that's going to modify their arousal levels, increase their activity, and improve their self-confidence, I clinically I'm not concerned about the level of evidence base. I mean, I know that sounds kind of crazy, but we don't have a ton of evidence, for example, with massage or acupuncture or these, certain types of exercise, yoga. But to me, those are all in the same spirit of building self-confidence, modifying arousal and stress, building resilience, and sort of building that acceptance of, I have to take care of myself. So I think anything people are willing to do, to modify those factors that we do know drive chronic pain at the level of the brain, um, is probably fair game.
Yeah, this is really interesting, that point that you bring up, because it's something difficult to study in our typical randomized controlled trials. You would need
Yep.
a large number of patients, very difficult to implement and make sure that there's compliance with, doing 3 or 4 different things. And
Yep.
I personally have come to the same conclusion.
Yep.
If somebody asks me, does this supplement work? Yeah, I do want to see a randomized controlled trial.
Mhm.
If somebody asks me what's the best therapy for, um, for an IBD patient, I would say, yeah, you can look at the clinical trial results with a biologic, but then for the overall treatment, that's much more difficult, and we don't have the studies to use, the traditional ways of proving that.
Right. And you don't want to wait. I mean, studies can take, 10 years, especially like clinical behavioral studies. I mean, you remember the IBSOS clinical trial, right? Which was like a 9-year project to be able to really follow people long enough to make sure that, the changes were indeed due to the skills training and not to placebo or not to other things they were already doing or the natural history of a chronic GI condition.
Yeah, and I mean, it was nice in that particular study that, we could show that there was a relationship of brain changes in the responders to this intervention,
Mhm.
um, and
Yeah.
also microbiome changes. So, I mean, this to me, to this
Yep.
date, it's still one of the few studies where that was able to actually demonstrate the biological components to the improvement.
Yep. That's right. And I think that helps with the uptake for patients too, because it really does destigmatize these disorders and these treatments, right? They're really targeting your GI symptoms and your GI specific quality of life, regardless of whether you have depression or anxiety or, fear or any of those issues.
Now, let me ask you this about the individualized approach. So there's multiple modalities that are available now, and some of them have been studied. So I would just like to call them brain-targeted or mind-targeted therapies, from CBT to hypnosis to
Mhm.
abdominal breathing. How do you decide in a given patient which one of these is going to be most effective?
That's a tough question. I mean, again, I think this is the good news is that we are really starting to understand the mediators and moderators of these classes of therapy, right? And you mentioned a couple of the classes. Cognitive behavior therapy is a class of brain gut behavior therapy. Gut directed hypnosis is a class. Self-management training is a class of therapies. I think those are the 3 that have the most evidence. But there are things on mindfulness-based approaches and more psychodynamic approaches as well. But if you think about the mediators and moderators of these, some of them overlap and some of them are really separate. And so something like cognitive behavior therapy, what we're seeing as a potential, one of the most powerful techniques that we offer in that type of class of therapy is exposure, right? So with the theory that patients who are avoidant of things actually become more fearful over time the more they avoid, and that the remediation of that avoidance, working with a therapist to kind of build your courage and start to try things that were naturally, you wanted to avoid them initially when you had symptoms, but now it's not adaptive. And so really working on avoidance behavior, working on catastrophizing, something like a CBT might be really appropriate. But there are other patients who are not really avoiding anything. They're not really cognitively catastrophizing, but they have a lot of circulating symptoms, right? So they have physical, in addition to their abdominal pain, they have back pain and hip pain. They're fatigued. They don't sleep well, right? And we know that one of the mediators and most effective ingredients for those patients tends to be those hypnotic suggestions, right? And so for patients who have a lot of that, we might be more likely to pick a hypnosis. And then a lot of patients, particularly at the milder level, really just need that guided self-management training, right? Constipation, getting on a routine, getting reasonable sleep, training the body to eat at certain times, to toilet at certain times, to, not hold on to stool when you, could technically go because you're afraid to go to the bathroom in a public place. Again, you're really, I mean, the beauty of these brain gut behavior therapies, especially now that we know, and again, some of this comes from your brain imaging work, but now that we kind of know what the key ingredients are that seem to work the best instead of just the kitchen sink, we are able to be more precise in who we pick for what therapy.
Now, in the real world, in typical, these patients see a gastroenterologist or the general practitioner. Would that person be expected to make this decision or this assessment? Is that possible? And how many practices have a psychologist like yourself or with similar background and training?
Yeah, so that's a great question. I mean, that speaks to the scalability and the accessibility of these interventions. So, most academic medical centers in the United States now have a gastropsychologist embedded, right? And so that's huge because obviously when I started, that was not even a job, right? And so um, most of these centers for excellence, academic centers, have been able to hire and have somebody who specializes in gastropsychology. But even when they have a gastropsychologist present on site, what we still are telling our GI colleagues is to refer for evaluation for the appropriateness of a brain gut behavior therapy. And I always tease because I say, just like you wouldn't want me to recommend which PPI you assign your patient or which biologic you give your patient, right? Let me decide what type of intervention they should be getting. And because there is a lot to be said for the assessment, we kind of have a four-step approach. To a gastropsychologist has a four-step approach, right? We look at the medical record, we look at the physiology, the anatomy, are you missing part of your colon? Like what's expected in terms of your absorption and nutrition? What's your bowel form consistency supposed to look like, right? We map their brain gut journey, right? What was your diagnostic process? Do you believe your doctor? Do you understand the connection between the brain and the gut and stress in your body? Then we look at these influencers. Do you have depression? Do you have anxiety? Do you have a trauma history? And then from there, the gastropsychologist is going to pick what the best targets are, what the best techniques are, and they're going to assign it. So I do think when possible, referring out for your psychologist because you're going to get a much more personalized, precise intervention. That said, because we've gotten a lot better at identifying the techniques and the targets of the interventions, there are ways to get access without the psychologist. We can train nurses in a lot of these CBT principles. We can train nurses in hypnosis. And then our physician colleagues can certainly do diaphragmatic breathing, belly breathing. They can, a lot of what we do as psychologists that can be done by a gastroenterologist is psychoeducation about why these symptoms occur, decatastrophizing them, reassuring them that they're false alarms. There's a lot that can be done by the gastroenterologist as we become more and more advanced as gastropsychologists. I'm hoping to see more of that embedded.
In this context, do you think that web-based modalities or versions of these therapies are close to being, a good substitute for the face-to-face interactions?
Yeah, that's a good question. I mean, I think there's a lot of controversy around that, right? I think we don't really have any good trials to show how they hold up against traditional behavioral therapies. Most of them don't have, most of the studies that have been done don't have control groups. Many of them have been compared or have been adapted from a therapist delivered protocol to digital. And we know that people learn differently and have different digital access. Um, I think that the great thing about these digital therapeutics is that you can expose people to these concepts that they may have never previously been exposed to. They may not even be seeing a gastroenterologist for their condition, and this kind of and these are stigmatizing disorders. So being able to download an app and practice and learn a little bit about your why you have IBS, for example, um, can be really helpful. I think the warning I would say is, and I see this a lot when I hear my colleagues talk, these are not brain gut behavior therapies. These are digital self-management tools, right? And so I think we have to be really disciplined about separating that out, because what you don't want is a patient to say, I tried hypnosis, I tried CBT, and it didn't work for me. That, we want to kind of make it so, just like if you had a patient who came in and said they had trouble sleeping, there's some great CBT insomnia apps out there, right? That you could say, well, why don't you take a look at this app? The patient has, time management issues. Try this app, right? Mindfulness, try, like anything someone's going to do to self-manage, I think is great. I just think we have to be careful not to conflate the digital therapeutics with brain gut behavior therapies. And because they are, I would say there's not the same evidence base, but theoretically, they're also very, very different.
Yeah, and I have to say from personal experience, so when I was in my fellowship training at UCLA, I always had that interest in the mind-gut connection. So I went to weekend workshops on hypnosis, Ericksonian hypnosis at the time. And I have to say the face-to-face experiences of these therapies is obviously something you could never reproduce on, sometimes when I drove home so I went to some of these training seminars like in Esalen or in Northern California. Sometimes I was so affected by this that I was afraid I couldn't drive home because I was in a
Yep.
different state of mind. I don't think you would ever get that deep, influenced by
No, and frankly, you can't. I mean, I think you have to be, I mean, certainly on the hypnosis apps, right? Like without a clinician to make sure you're safe to drive home, to make sure you're not re-traumatized by some memory that kind of, I mean, I think you have to, so by design, a lot of these hypnotherapy apps, at least, are more what we would consider hypnotically assisted relaxation, right? Versus hypnosis, because exactly what you're describing, right? There's a huge therapeutic judgment there um, that you really can't replicate without a human contact.
Yeah, people, along the same lines, people underestimate the power of these techniques if they're done with a therapist that you can relate to. They're very powerful on your whole body, not just on the way you think. And
Yeah. And, we train for a long time to pick up on a lot of the subtle cues that you could never replicate in an app, right? Noticing that somebody crosses their arms, notice that somebody's sitting on the edge of their chair. Those are all things that a psychologist is going to be very aware of and adapt their messaging and motivate the patient to change. You can't really put a number on that, right? That's very hard to replicate in any kind of digital form.
I'm going to bring up a question along these lines, and it's sort of like going to the extreme end of this. So there's a lot of talk about psychedelic assisted psychotherapy, and when you look at some of the early results that are coming out now, I mean, they're pretty impressive in terms of depression and like long-lasting effects. Um, even after one session with these. Is this something that you foresee in the future will enter the field?
Yeah, it's funny you say that. So, at Mount Sinai, we have a big center for psychedelic medicine. Dr. Rachel Yehuda is very involved in that, particularly in the veteran population, right, where they look at, long-standing complex trauma, give psychedelics, and it really unlocks something in the brain that allows people to properly process it. So I think from a scientific perspective, the data is building, which it gives me a lot of hope. I think that, again, just like with what we're talking about with brain gut behavior therapies, clinicians really need to be guiding these things, right? And one of the concerns I have, I think it's fine when you have somebody who's in the field doing the science, theoretically deciding who's appropriate and who's not, who's likely to have risk and who's not. And being able to manage adverse events as they occur or if it doesn't work versus, I get in my mail almost daily, invitation to go to a psychedelic training retreat, usually in like Colorado or California, right? Where I can go and learn to be a therapist, psychedelic assisted therapy. To me, that makes it a lot more concerning, right? Because I think just like we wouldn't want, somebody that's not already familiar with a particular, disorder to provide a treatment, just like, you're not going to give hypnosis to every single patient if you're only a hypnotherapist. That's not going to really work. So I think I see a lot of the scientific promise, but again, I think regulating who can actually deliver these interventions, because I don't think it's just the psychedelic. I think it's the therapy that goes with it that's so beneficial.
Absolutely. I mean, there was a recent paper that came out in the journal Nature with brain imaging, where they showed that basically the connectivity between different brain networks is altered from repeated courses of psilocybin, and that persisted for several months after the treatment. And that's kind of interesting because loosening the connections between the traditional connections between these networks determines how you think and how you feel. It's almost like like electroshock therapy of the brain, that you reset a lot of the connections. And
Yep.
I feel that without the therapist, it's not going to do the job. It's just you get the opportunity once everything is loosened up, so you can go in and change certain maladaptive connectivities and associations within brain networks. I mean, that's
And
good.
I mean, we can do that anyways, right? With a lot of like, if you look at the trauma research in particular, right? Prolonged exposure, cognitive reprocessing therapy, those also by definition, EMDR even, I think those are also trying to change those networks of traumatic memories and reprocessing, right? And they don't involve any psychedelics, right? I think for these really refractory or for some people who just really are so defensive and unable to open up that part of their brain to a therapist in the human relationship, maybe the psychedelics kind of open the door a little bit but again, that's not for the masses,
Yeah.
right?
And it's once it's shown to be effective in larger studies, it's still the question, like the economic aspect of it. It's going to be expensive because it's not like you can't just give somebody the psilocybin and go home and do it. You need a trained staff and professionals that supervise it. And is this realistic in the current situation where there's cost cutting by medical centers constantly.
And the mental health crisis. I mean, there's a shortage of therapists. There's an epidemic of mental health concerns. How are you going to manage that?
I mean, there's a lot of things that we discussed when we wrote this review article on pain management. So this would be basically something of great interest to an IBD patient who has had effective therapies. So there's mucosal healing based on biopsies or stool fecal calprotectin. But that person still has a lot of pain, and it's we've gone away from this as well as just IBS. This person had IBS, and it seemed to be a higher percentage of people that develop this after these symptoms, persistent pain symptoms, after having been diagnosed and treated for IBD than there are in the normal population, between 4 maximally 10% population. So there's obviously other things going on, and so if this patient comes to you, is referred to you by his or her gastroenterologist, so what would be the step approach that you would recommend? I mean, you were saying earlier you would do this detailed assessment and then personalize the treatment. That would be an important component, I imagine.
Yeah. Yeah. I mean, I think, really kind of, doubling down on that, I think, because IBD is so heterogeneous, right? There is a lot of nuance and there's a lot of things we don't know, frankly, around things like pain. And, pain at the anastomosis is very common. People have adhesions, some of which you can tell, and sometimes you can't until you have a surgery. Sometimes, there are explanations for pain that go away, kind of come and go. And unless you catch them in that moment, it's going to look like you don't have an explanation for your pain. So I think I often like to start by sort of telling the patients that, we don't always have explanations for pain, but that never sort of suggests that it's not real. And I think that's really important to getting that buy-in. But, if we're going to be stuck with, this persistent pain, we need to understand what pain is threatening and what pain is not. Now, this is interesting because when you treat like irritable bowel syndrome or these lower mortality, morbidity risk disorders, you can be a lot heavier handed. You can say, this is always a false alarm. This is faulty signaling. There's no, concerns. You take a Crohn's patient or an ulcerative colitis patient who's had an obstruction, who's had a perforation, who's needed ileoclonic resection, who's has scar tissue and adhesions, who's responsive to, has side effects to medications, had trauma related to feeding tubes. It's not the same. You can't quite just say, whenever you have pain, whenever you have a symptom, it's your brain misinterpreting it. You have to really shift into, how do I know when pain is chronic, persistent, hypersensitivity, versus when is it something that I have to actually take action on? And I think that is a nuance that's hard for me as a psychologist to work with patients. And it's a lot of just really trying to build that confidence of, your body is here to protect you. Your body's going to let you know when pain is an obstruction, when pain is something, more urgent, and when it's not. And so we spend a lot of time in that area. And then once they have a better sense of what pain is what, right? What's my anastomosis pain? What's my obstruction pain, right? Then we're able to personalize the techniques to those different issues, right? Because some of the techniques these are controllable situations, right? I ate a piece of asparagus, it got stuck, I'm feeling discomfort, it's not going down with some warm water. The pain is maybe something I need to go in for. Versus I'm having some, pain. I'm nervous about going to an event at work and I'm feeling a little bit uncomfortable. Those are two separate techniques. One is going to be to tolerate, to dampen down, to decatastrophize, to modify arousal to keep yourself comfortable. The other is going to be to hop into action and to do something according to what your doctor told you, right? So anyways, long story, so I think that there's, that nuance. And then the other layer is that no matter what the origin of your pain, right, we want everyone to be resilient and we want everyone to modify arousal and keep their stress levels low, again, so that they can really determine when something potentially bad happens, that it's not due to their stress and arousal, and that it's actually that saber-toothed tiger coming down the mountain and not just a perception of stress.
Yeah, and there's also, I mean, these things. So we're in the midst of writing a grant proposal on this stress responsiveness concept that, the variation. So, I mean, we all live in a world of stress, increasing amount of stress. Like when, I think humans probably have hardly ever been as stressed about a lot of situations, from climate change to political situations. But not everybody responds the same way to it, So this variability in the responsiveness to stress seems to be a big determinant what the outcome is. So for some people, and it goes a little bit with resilience, that you're resilient to stress. Another way of saying it. Is this part of? I mean, this must be part of the therapy that you also, this instrumentarium that you have to decrease this subjective overreactive stress responsiveness.
Yeah, absolutely. Because, I think when, listen, stress doesn't help anything. When you're stressed, you're going to be more focused in on the bad things, right? You're going to be more likely to interpret something that somebody says to you as malintentioned. You're going to be more likely to feel pain and discomfort. So it's a choice, right? We're not saying that it's not stressful. We're just saying that, if you can approach stress, and we always talk about the 3 Ps as not personal, not permanent, and not pervasive, right? That may or may not be accurate or the real deal, but it's certainly going to help you get through something, right? It's going to make you more resilient. And these are things that you can learn, right? And so that applies no matter what's going on. And certainly in our IBD patients, learned optimism is a huge skill that we try to teach to everyone, because the optimism is associated with longevity and lower morbidity and mortality, better heart functioning, better metabolics. So there's something to it, and it can be learned. So again, I think about these, not everyone is born with the same stress resilience, but there are things that can be learned to really build that, resistance a little bit.
Mm-hmm. Yeah, I think we've almost come to the end of our time. Could go on for a long time talking about these topics with you. Um, one last question, looking at the crystal ball. So you've seen a remarkable change in this field during your career. And now, I mean, I've heard some, and I think it was a big breakthrough, coming up with this new understanding of, or nomenclature for DGBIs, the sort of altered gut-brain interactions. And but I heard that there have been voices, I've heard the rumors, there have been voices that actually are opposing that and would like to move it back to where it was, more on the gut. Do you think this evolution in what we consider the right direction will continue, or do you think there's going to be setbacks and there's going to be generations of gastroenterologists to say all this crap, if we basically just want to focus on the gut and not these vague things about the brain and the mind?
Yeah, it's so interesting you say that. Yeah, I'm really worried about that. I think, we put a lot of thought during Rome 4 and relabeling these as, disorders of gut-brain interaction, really with the goal of destigmatizing them and speaking to the pathophysiology of them, right? I think what has happened though, and maybe this is a PR or marketing issue that we need to think about, is it's implied that the brain is our focus, right? And for whatever reason, it's sort of been conflated with, if we're adding brain to this term, now we're talking about psych, right? And I think that misses the point. The point was meant to reflect that gut-brain microbiome axis and not take away from that, but recognizing the complexity of these disorders and the broad approach to treatment that, these disorders sort of deserve. I think whenever you have something that is more holistic, you're faced with this reductionistic backlash, right? Of like, we just need to keep honing in on this smaller and smaller mechanism. Gastroparesis, that's gastroparesis is like the perfect, example, right, of a disease that we've really not addressed any behavioral or mind or body connections with, and have just continued to focus honing in on motility and what constitutes delayed gastric emptying, and we've done a disservice to this patient population, and I think, thinking about these as disorders of gut brain interaction, motility disorders, it's a shame to kind of keep focusing in on that reductionistic viewpoint. I think the other problem is, and this is a US based problem, is the term functional got conflated with psych. I think if you go to other countries, and we've seen this even within the Rome population, functional is a relief, right? It means, oh, good, I don't have something structural or organic going on. I'm glad to carry a functional diagnosis. Because of our health system in the US, I think people see functional as a sign that your doctor doesn't believe you, that there's nothing wrong with you and it's your fault. So we have to do a PR blast, right? To really go back to, like, these are disorders of gut brain interaction, or these are disorders of motility because of gut brain interaction. And make it seem a little bit more holistic, but in a positive way. Because otherwise, I agree with you. I am afraid that there's going to be a strong push against it because it's being conflated with brain.
Yeah. Yeah, it's unfortunate. I mean, hopefully I won't have to experience that. Would be really, really disappointing, I have to say. But let's be optimistic. It's good for our longevity. It's good for
Yes. Yes. We have to practice what we preach here, right?
Okay, so thanks, Laurie. It was great talking to you as always. And
Yes.
yeah, I'm looking forward to interacting with you in this on these topics. So thank you
Yeah.
very much.
Yeah, my pleasure.